Hi guys. Sorry for the issue. I think there was a bit of a technical issue at my end and the stream suddenly kind of ended. So yeah, let's kind of continue. Okay. Yeah, sorry for the inconvenience. Okay, so let's try to talk about this. What somebody had asked me about the Pusto's procedure, right? So I hope you guys are here. I'm audible and visible to you properly, right? Yep. I hope I'm audible and visible to you properly, guys. Okay. Now, what you need to understand over here that we were talking about the Pusto's procedure. So what was the Pusto's procedure? In this, what you basically do is that you open the pancreas like this. Okay. So longitudinally open the pancreas. Now, in this particular pancreas, in the main pancreas, what are there? There are multiple dilatations and the strictures are basically present along the length of this particular main pancreatic duct. So what you do is you bring the loop of the jejunum and you attach it to this particular part. Okay. So you bring a loop of the jejunum and you attach it on this particular longitudinal, like whatever the portion of the pancreas which you have opened, you basically attach that particular jejunum over there. Are you understand my point? So that is what you need to understand in the Pusto's procedure. Okay, so just to summarize, I had shown in this particular image, this is what is the biggest procedure, duodenum preserving pancreatic head resection. And now what we have is, somebody had asked me about the Pusto's procedure. So Pusto's procedure is a longitudinal pancreaticojejunostomy where we open the pancreas longitudinally and we bring the loop of the jejunum and we attach the loop of the jejunum over here. So this is what is called as a longitudinal pancreaticojejunostomy or the Pusto's procedure. Okay, I hope you have understood this particular point, guys. Okay, got it? Okay, so this is a longitudinal pancreaticojejunostomy or the Pusto's procedure. Okay, now Whipple's procedure is nothing here. What we basically do is we remove everything. Okay, so in the Whipple's procedure, what you basically do is that let's say if at all this is the stomach. Okay, so let's say if at all this is the stomach, this is the loop of the duodenum. Okay, this is the loop of the duodenum, and yeah, over here what we have is we have the pancreatic tissue like this. Okay, so we have a pancreatic tissue like this, and over here what we have is we have the liver. Okay, so what we have is we have the liver, and what we have is we have the right and the left hepatic duct, then we have a common hepatic duct, then we have a cystic duct, we have a common bile duct. So this common bile duct is basically opening in this particular duodenum. Are you understand my point? So this is what you know. Now here what we do is in the Whipple's procedure we remove all these things. Okay, we remove all these things. Okay, so what I'll do is I'll just kind of remove these particular stuff. Okay, so what I'll do first, I'll kind of copy it and then I'll remove it. Okay, so please try to understand. What we do is we remove all these things from here. Just give me a minute, you will understand the Whipple's procedure today. Okay, so what we do is we remove all these things over here. Okay, so what we do, we remove the pancreas, the head of the pancreas, everything. We remove the part of the stomach, we remove this particular duodenum, we remove this particular jejunum as well. Okay, you understand my point? So you remove all these particular things from here. Now what you do is you bring the loop of the jejunum. Okay, so you bring the loop of the jejunum and you attach this particular loop of the jejunum to all these things. Okay, so you bring the loop of the jejunum and you attach this particular jejunum to all these things. So this is how you get the three anastomosis over here: pancreaticojejunostomy, gastrojejunostomy, choledochojejunostomy. Okay, or hepaticojejunostomy, whatever you want to call it. Okay, so choledochojejunostomy, hepaticojejunostomy, and yeah, so choledochojejunostomy, hepaticojejunostomy, gastrojejunostomy, and the pancreaticojejunostomy. Are you understanding my point? So this is what you basically do in the patients with the Whipple's procedure. Okay, no, Priyanka, in the what you call as the insulinoma patients, what we basically perform is an enucleation. Okay, because insulinoma is a benign condition, so there the treatment of choice is enucleation. Okay, so that is what you need to understand. Now, what is this? What are you basically seeing over here? What is this particular stuff? So this is what is your SEMS. What is this SEMS? This is what is your self-expandable metallic stent. Okay, so what is this? This is a self-expandable metallic stent. Okay, so this is basically used as a palliative procedure. Okay, so this is basically used for palliation in patients with esophageal carcinoma. Okay, in the metastatic esophageal carcinoma, not in the simple esophageal carcinoma. If at all there is a metastasis, okay, where you cannot save the life of this particular patient, and yeah, all you basically need to do is what you call as like the palliative procedure, like palliative, like you just want to kind of ensure that whatever the life the patient is having, the patient basically leads a symptomless life. In that particular cases, what you basically do is you use this particular self-expandable metallic stent. Are you understanding my point? So self-expandable metallic stent is used as a palliative option in the patients with a metastatic esophageal cancer. Okay, I hope you are able to understand these particular points, guys. Okay, got it. Now let's move on to the next kind of question. Now this is a bit kind of a weird question, funny question, but yeah, let's try to kind of understand it. There is a patient who underwent an ESWL, has been subjected to a CT scan. What are you basically seeing? Are you understanding my point? So okay, so Priyanka, you will get the PDF of this particular class on the group of the, what do you call as this, Dr. Bhanu sir's group. The link is basically in the description below, and once you go on that particular group, they will upload the video over there. Yep. Okay, got it. So yep, all those people who are basically asking for the PDF, you will get it on the group after the classes kind of ending, right? Okay, so coming back to this particular question, what you need to understand that ESWL was performed, and after performing an ESWL, you performed a CT scan in this particular patient and you found this. Okay, so what are you basically seeing this? Are you able to appreciate that there is some abnormality over here? What is this particular abnormality? So this is what is, have you ever heard of Steenstra's? Okay, so what is this? This is a complication of the ESWL, which is called as a Steenstra's. So what you happened in this particular Steenstra's is that there is a lead fragment. Okay, so what happens is that there is a lead fragment. Okay, so there is a lead fragment, and what happens is that the other smaller pieces of the stone, they basically line up behind this. Okay, so this is what is called as a Steenstra's or the street of stones. Okay, so yes, absolutely right, Steenstra's or the row of the stones or the kind of street of stones. So this is what is a CT scan which is showing this particular Steenstra's. Okay, okay, right. Okay, that's great. Now let's move on to the next particular question. What has been shown, okay, over here? So again, I'll have to kind of move away from this particular image. So what is basically shown over here? So what is this? This is a repeat question, guys, from your like FMGs. What is this? Okay, what is this? So I hope you're able to appreciate that this is what is your, come on guys, put your answers. Angled stapler, really? Okay, I understand that the image is not really kind of coming in a good manner over there, but this is the kind of a stapler, guys. Okay, so this is kind of a stapler. So now I'm trying to draw the boundary of this. Okay, so now I'm trying to draw the boundary of this particular stapler. So this is what is a stapler. So yeah, this is what is a skin stapler, guys. Okay, what is this? This is what is a skin stapler. The image is appearing a bit weird. I'm seeing it on the screen. It is different on my PDF and over here, but that's fine. So what is this? This is what is a skin stapler, guys. Okay, so this is what is a skin stapler. This is has been asked to you in your exams. Okay, now what is this? What is this? Now, can you please help me with this? What is this? So this is what is your linear stapler. Okay, so this is what is a linear stapler. So where do you use this? So let's say if at all you want to do a bowel anastomosis or something like that, you're going to use this. What is this going to do? This is going to cut the bowel and it is going to staple the bowel at the same time. Okay, right. Okay, so what is this? This is what is a linear stapler. I hope you're able to appreciate this. So what is this? This is what is a linear cutting stapler, which you basically use in the patients when you are wanting to perform the bowel anastomosis. Okay, what is this? This is what is a stapler for the hemorrhoids. It is also called as a PPH stapler. That is procedure for the prolapsed hemorrhoids. Okay, so this is what is called as a PPH stapler. Okay, so what is this PPH? This is what is called as a procedure for prolapsed hemorrhoids. Okay, so this is what is your PPH stapler, which you basically use for the hemorrhoids surgery. Okay, so this is basically used for the hemorrhoids surgery. Please try to understand over here. It is not bill rod. This is a hemorrhoids. This is basically used for the hemorrhoids patients. Okay, now what is this? This is like after you have done the hemorrhoidectomy. Okay, you have to ensure that all the sides the hemorrhoids have been kind of removed. Okay, so what is this? This is like a donut. Okay, so this is like a donut. You basically check the integrity of the donut. If at all you have kind of checked the integrity of the donut, this basically tells you that, you know what, that is the hemorrhoids has been kind of taken care of in a good manner. Okay, so I hope you are able to appreciate this. Okay, what is this? This is what is a circular stapler. Okay, what is this? This is what is a circular stapler. Okay, so what is this? This is what is a circular stapler, which is basically used for the GI anastomosis. Okay, So this is basically used for your GI anastomosis. Okay, so GI anastomosis, what you basically use is a circular stapler. Do not confuse this with the PPH stapler. They are different. This is basically used for the hemorrhoids, and this is what is used for the bowel anastomosis. This is what is a this is very, very commonly, like the surgery cannot be done without this particular stapler. What is this? That is a low anterior resection. Okay, so low anterior resection. This particular procedure cannot be completed if at all you're not using this particular stapler. Are you understand my point? We need this particular stapler for that. Okay, I hope you're able to understand this point. Okay, right. So this is how you use the circular stapler in order to kind of do the bowel anastomosis. That's fine. That's not a very, very big deal. This is again trying to tell you. So this is what I was trying to talk to you about, the integrity of the donut. Okay, so you have to ensure that the integrity of the donut is complete. If at all like it's like this, it means that your stapler was not fired in a proper manner. Are you understand my point? So very, very important. Whenever you fire a circular stapler or whenever you basically fire this hemorrhoid stapler, you have to look for the integrity of the donut. Okay, so that is very, very important. Okay. What about wiring? So wiring is basically done, not done in today's time, right? We do not kind of use. So first of all, wiring, triage wiring is basically used for the rectal prolapse. It is not used for the hemorrhoids. Okay, so you are confusing, Sai Krishna. This wiring is basically used for your rectal prolapse, triage wiring. Okay, it is not used for your hemorrhoids. Okay, so how to measure the nasogastric tube length? Okay, how do you measure the length of the nasogastric tube? How do you kind of do that? So yeah, it is basically from the tip of the nose to the kind of ears, and from the ears to the xiphisternum. This is how you measure the tip of the nasogastric tube. Okay, so as you can see over here, from nose to the earlobe, from the earlobe to the xiphisternum. Okay, so this is how you kind of measure the length of the what you call as a nasogastric tube. Very, very important. Okay, so this is how you measure the length of the nasogastric tube. Understood? Got it? Right. Yeah. Okay, nothing major. So what like the following instrument is used for the removal of the stone in what? Okay, so now I understand that this you might not have seen. So this is what is called as a lithotrite. Okay, what is this? This is what is called as a lithotrite. Okay, just kind of apply your brains, and can you please tell me where do you are you going to use this? So this is going to be used in removing the stones from the bladder, from the urinary bladder, guys. Okay, so what you need to understand is, you would have read this. Okay, you would have read this, that if at all there is a urinary bladder calculi. Okay, so if at all there is a urinary bladder calculi, what you need to do is, if at all the size of the stone is less than 2 centimeters, you can perform an endoscopic procedure. Okay, so what you basically do in this particular endoscopic procedure, you go in with a lithotrite, and with the help of the lithotrite, what you do, you crush the stone. Okay, so you crush the stone with the help of this lithotrite. So the lithotrite is basically called as a stone crushing instrument. Okay, so what is this called as a stone crushing instrument? So what you basically do is, you go in with an endoscope, you catch hold of that particular stone and you crush it. So once you crush it, it basically kind of boils down into the small pieces, and these particular small pieces can be removed inside the urine. Okay, so for the smallest urinary bladder stones, what you basically can perform is this. So what is the procedure known as? This is called as the cystolithotrypsy. Okay, so this is what is called as a cystolithotrypsy or the cystolithotrypsy. Okay, so I'll just write it down. So cystolithotrypsy. Okay, so cysto basically means cystoscopy, litho means like the stone, trypsy basically means kind of breaking it down. Okay, so cystoscopy karke you have broken down the stone. That is what is called as a cystolithotrypsy. Okay, now if at all it is more than 2 centimeters, then you have to perform an open cystolithotomy. So here you have to kind of give an incision on the urinary bladder, like you have to kind of do an open surgery, and you have to kind of remove the stone. So this is what is, if at all it is more than 2 centimeters, that's fine. Okay, so this is what is a lithotrite. Again, not a very, very important thing, but yeah, I just kind of thought of showing it to you. Okay, now what is the most common complication while inserting this particular catheter? So what are you basically seeing on the screens? This is what is a central venous catheter. Okay, so what is this? This is what is a central venous catheter. So what you need to understand is that this particular catheter, like in today's time, many times you kind of put it under the ultrasound guidance, but we had kind of put, like during our residency, we used to put this very blind. So just below this particular clavicle, we used to kind of aim towards the opposite tip of the opposite shoulder, and then we used to kind of put this particular central line. Okay, now the most common complication while putting this particular central line is the pneumothorax, because the apices of the lungs, they basically come up, and if at all the apices of the lungs are basically going to come up, then you might end up injuring those particular apices, the pleura, the pleural apices, that's fine, and the patients will end up into the pneumothorax. Okay, I hope you are able to understand this point. The most common complication while inserting this particular catheter is the pneumothorax. Okay, I hope you have understood this particular point. Okay, now what is an indication of performing this particular surgery over here? Okay, so what is the indication of performing the this particular surgery in these particular patients? Okay, so please try to understand what is the answer over here. Okay, so this is what is your, okay, so it's not kind of completely visible over here. Okay, so what is the indication of performing this particular surgery over here? Can you please help me with this? Yep, what's your answer, guys? Yes, it is basically hydrocephalus, right? Okay, so this is basically hydrocephalus. So what is this? This is what is called as a ventriculoperitoneal shunt. Okay, so what is this? This is what is a ventriculoperitoneal shunt, and this is basically done in the patients with the hydrocephalus. So this is what is your ventriculoperitoneal shunt. Okay, and this is what is basically done in the patients with the hydrocephalus. Okay, in the patients with the hydrocephalus, what you perform is this ventriculoperitoneal shunt. Okay. Right, that's fine. Now, what is the management of this particular patient? Okay, again, I'll just kind of enlarge this particular image. So first of all, tell me what is the diagnosis over here. Okay, first look at this particular image. Okay, what do you think? What is the diagnosis over here? Put it in the comment box. And now you can tell me what is the management of this particular condition. What do you think? How are you going to manage these particular patients? So how are you going to manage these particular patients? The management of this particular patient is going to be ICD, intercostal drainage, ICD insertion, because here probably the patient is having a hemothorax. The patients might also be having a pleural effusion. Okay, because here the history has not been given, and the image of your hemothorax and the pleural effusion is very much kind of similar. Okay, but in both the scenarios you have to kind of put in ICD, intercostal drain has to be kind of inserted in these particular patients. Okay, very important. So we have talked about the image of a pneumothorax, right, where I told you that there is that particular part of the lung appears more black as compared to the opposite side. Over here, what you're able to appreciate that this particular part of the lung is appearing more white as compared to the other. So this is what is called as a white out lung. Okay, so what is this? This is what is a white out lung. Okay, it's not a collapse, okay, so this is what is a white out lung. Okay, so in the collapse, what you need to understand is Farah's, in the collapse, what is going to happen, that the lungs are going to get collapsed. So there's going to be this, like over here, there's going to be extremely white, that's fine, but the rest of the lung is going to be very black. Okay, are you understanding? Because there will be no bronchovascular marking. So that is what you basically get in the pneumothorax. This is what is the hemothorax, white out lung. Okay, now I just ask you over here that what is the indication? Okay, so once you have performed this particular ICD insertion, okay, so is it like the end of the story, or do you need to monitor or something like that? So if I ask you, what are the indications of thoracotomy? Okay, so can you please help me? What are the indications of a thoracotomy? Okay, yeah, can you please help me with this? What are the indications of the thoracotomy? The indications of the thoracotomy are, what are these? Okay, so the indications of thoracotomy are, let's say if at all, the stat output. Okay, the stat output is basically more than 1.5 liters in case of a blunt trauma, or if at all it is more than 1 liters in case of a penetrating trauma. Okay, so if at all the stat output is basically more than 1.5 liters in case of a blunt trauma, or let's say more than 1 liter in case of a penetrating trauma, that is one of the indications. Well, what else? So you monitor these particular patients. Okay, so you monitor these particular patients, and in monitoring, if at all you get more than 200 ml per hour for 3 consecutive hours. Okay, so if at all you get the output of 200 ml per hour for more than 3 consecutive hours, this is again an indication of performing a thoracotomy. So please try to understand over here, these are the indications of performing a thoracotomy in these particular patients. Okay, I hope you have understood this particular point, guys. Okay, now what has been shown in this particular image. Okay, so I'm trying to show you this particular image. I'll go out of the vision. So yeah, just look at this. What are these particular pins? And now you can tell me what is this particular stuff. Okay, so yeah, what is the thing? Is it like a bone marrow biopsy cannula, intraventricular drain, intraosseous line, or burr hole cannula? Okay, so what is this? Yes, absolutely right. This is what is your intraosseous line. Okay, so what is this? This is what is your intraosseous line. Now what you need to understand is that whenever there is a patient with a trauma, okay, so whenever there is a patient with a trauma, when the patient comes to the kind of emergency, what you basically do, you follow the ATLS guidelines, and then you basically follow this A, B, C, D. So this is A is for airway, B is for breathing, then C is basically for the circulation. So when you basically reach to this particular circulation part, the first step, what is the first step in this? So the first step is that you have to kind of maintain the IV line. Okay, so you have to kind of maintain the IV line. It means that you have to put something in, you have to kind of get the IV access of this particular patient. Are you understand my point? So you have to get the IV access. For this, what is the preferred cannula which you prefer? We've talked about this today itself, right? So what is the preferred IV cannula which you prefer? The preferred IV cannula is 18 gauge cannula, which is basically your green cannula. What is the flow rate in this particular green cannula? 90 ml per minute. Okay, so this is what is the preferred one. But many times what happens, due to the sympathetic overactivity, there is a peripheral vasoconstriction and you're not able to get the IV access. So if at all you're not able to get the IV access, then what you need to do is you have to go and look for the substitutes. And one of the substitutes for this particular stuff is intraosseous line. Intraosseous line, which you basically put in the children. Okay, in the children on the tibia, in the tibia you basically put this intraosseous line. Okay, so this is what is an intraosseous line, which you basically put in the tibia of the children. Okay, so I hope you are able to appreciate these particular stuff, guys. Okay, now what is the most common site of the bed sore? Now please answer. I want all of you to answer this particular question, guys. Okay, so what is the most common site of the bed sore? What is this? This images of the bed sore, right? So what is the most common site of a bed sore? Can you please help me with this? What is the most common site of the bed sore? Ischium, really? Sacrum, right? Yeah, sacrum, right, Yankee? Okay, guys, this has been asked so many times. Okay, good that many of you guys are answering it in a good manner. Oh, guys, no, A is not the answer. I was just kind of fooling around with you. The answer is ischium. A is basically the most common wrong answer which you basically get. Okay, it's the most common wrong answer. So what you need to understand, probably it's not your fault, because many times whenever you kind of get this particular bed sore, always you have been shown the images like this. Okay, and by looking at this you might say that, you know what, sacrum is the most common site. But please try to understand, this has been asked so many times. The most common site for the bed sore formation is the ischium. Okay, ischium. Okay, this they have asked so many times. So after this, what is it? There is a greater trochanter, and followed by this there is a sacrum. Okay, so there is a chance that in the next time they will not give the ischium in the option, they might give you greater trochanter and sacrum, all those particular stuff. So then again the answer is going to be the greater trochanter. You understand my point? So greater trochanter is the second most common site of the bed sore. Okay, you tell me what is the grade of this, Priyanka? Okay, is it the grade 3? Do you really think it's a grade 3 bed sore? No, I would argue, I would say that it is a grade 4 bed sore. Okay, so let me just ask you one question, guys. Okay, so let me just ask you one question. So let's say I tell you that there is a patient who is having just the superficial loss. It's a very simple question. Okay, superficial loss of epidermis with no loss of dermis. Okay, so there's just a superficial loss of epidermis with no loss of dermis. Okay, so what is this particular bed sore? Like, what is the grade of this particular bed sore? Can you please help me, anybody? What is the grade of this particular bed sore? Yeah, I want you guys to answer. Okay, so what is the grade of this particular bed sore? Grade 1, right? Yeah, obviously. Yeah, please put your answers, guys. Grade 1. No, guys. Okay, this is again the most common wrong answer which you get. Okay, so please try to understand. So let's talk about the grades of the bed sore. Okay, so what are the grades of the bed sore? What are the grades of the bed sore? The grades of the bed sore are, in the grade 1, what you basically get is a non-blanchable erythema. Okay, so what you basically get is a non-blanchable erythema. In the grade 2, what you basically get is, you get so there is non-blanchable erythema with no loss of epidermis. Okay, so it is a non-blanchable erythema with no loss of epidermis. What about the grade 2? In the grade 2, what you have that there is a superficial loss of epidermis with no loss of dermis. In the grade 3, what you have? In the grade 3, you have the loss of epidermis plus the dermis. And in the grade 4, what you have? That underlying muscles and the bones are involved. So the muscle and bone is involved. So what you need to involve. So what you need to understand is that in this particular image, definitely, like, it's not just limited to the skin, right? Underlying muscle, soft tissue definitely is kind of involved over here. So definitely that is what is a grade 4 bed sore, and do not forget about this, guys. Okay, so grade 1 is non-blanchable erythema with no loss of epidermis. Okay, so this is again a very, very important MCQ which they ask you, and many students mark it as grade 1, but it's not grade 1. What is it? It's grade 2 bed sore. Okay, I hope you have understood this particular point, guys. Yeah, everybody have got this. Now, this is a condition most commonly associated with what? Okay, so what is this? Yeah, can you please help me? What is this? This is what is eosinophilic esophagitis. Okay, so what are you basically finding is, so you are finding these particular coiled ring appearance. Okay, so multiple what you call as a webs kind of a thing which you're going to find over here. So a coin of stack appearance on the barium and a kind of swallow, and multiple concentric rings on the endoscopy. This is what is your esophageal like esophagitis. Okay, eosinophilic esophagitis. Okay, so please try to understand this. This is what is your eosinophilic esophagitis. Okay, I hope you have understood this particular point. Now let's move on to the next question. So a 3-week-old child comes to you with a non-bilious vomiting. What is the diagnosis of this particular patient? Okay, so 3-week-old child coming to you with a non-bilious vomiting. What is the diagnosis? The diagnosis of this particular patient is A. Yes, absolutely right. So what are you basically seeing in this particular image is that this is obviously an ultrasound, and what are you basically seeing is that the pylorus has become very, very thickened. Okay, so the pylorus has become very, very thickened. So this is what is your congenital hypertrophic pyloric stenosis. Okay, so please try to understand over here. This is what is a congenital hypertrophic pyloric stenosis. Here we get a non-bilious vomiting. That's fine. Now, if at all there is a non-bilious vomiting, okay, let's talk about this. Okay, so what is the most common metabolic abnormality which you basically get in these particular patients? Okay, so what is the most common metabolic abnormality which you basically get in these patients? Can you please help me with this? The most common metabolic abnormality which you get in these particular patients? Yeah, please put your answers in the comment box, guys. Okay, what is the most common metabolic abnormality which you get over here? Okay, so yes, hypokalemic, hypochloremic, metabolic alkalosis. Okay, so what you basically get over here, hypokalemic, hypochloremic metabolic alkalosis with paradoxical aciduria. Okay, so hypochloremic metabolic alkalosis with paradoxical aciduria. I hope you are able to understand this point. This is what is the most common metabolic abnormality which you basically get in these particular patients. Okay, now if at all you perform an ERCP, okay, so ERCP was done in this particular patient, and this was the finding which you got. Okay, so on the ERCP you got this kind of a finding. So what is the diagnosis of this? Yes, absolutely right. Okay, so what is this? This is what is an IPMN. And what is this particular image known as? Okay, what is this called as? Okay, so this is what is called as a fish mouth appearance. Okay, so what you basically called it as, please try to understand, this is what is called as a fish mouth appearance. Okay, so fish mouth appearance you basically get in the IPMN. What does this IPMN stands for? IPMN basically stands for intraductal papillary mucinous neoplasia. Okay, so this is what is a cystic lesions of the pancreas. Okay, what are these? These are the cystic lesions of the pancreas, And on ERCP, what are you going to find? You're going to find a fish mouth appearance. Okay, on the ERCP, you're going to find a fish mouth appearance. Okay, I hope you are able to understand this particular point. Okay, on the ERCP, you find a fish mouth appearance, and this is what is an intraductal papillary mucinous neoplasia. Okay, I hope you have understood this particular point. Very, very important. Okay, now let's move on to the next question. Not true about this particular condition is mostly unilateral. Okay, investigation of choice is an MRI. Okay, I'll just get out of the view. So yeah, so just look at this particular image. So what is not true about this particular condition? Mostly unilateral, investigation of choice is MRI, may have underlying malignancy. It is a carcinoma in situ of the breast. Okay, so what is the answer over here? Okay. So guys, we just talked about the indications of the MRI in the breast, right? Did I mention about this? Okay, first of all, what is the diagnosis over here? What is the diagnosis? So I hope that you are answering that the diagnosis of this particular patient is Paget's disease. Okay, so what is the diagnosis over here? The Paget's disease. So we just talked about the what you call as the indications of an MRI in the breast, right? So did I even mention about the Paget's disease in that? No, not really. So yes, MRI is not the investigation of choice, guys. Okay, so answer is B. Okay, so yes, it is B as the answer. So what is an investigation of choice over here? The investigation of choice over here is a biopsy. Okay, so please try to understand biopsy. A biopsy you have to take, and you basically have a characteristic Paget cells. Okay, so this is what is the cells with the clear cytoplasm. So in the biopsy, what you basically find is a clear cytoplasm. So what you basically find is a Paget cells. Okay, so what you basically find is a Paget cells. So what you basically find is the Paget cells, that is the cells with the clear cytoplasm, and that is what is the diagnosis of your Paget's disease. Okay, I hope you are able to understand this particular point. Not true is MRI is not the investigation of choice. Okay, now mostly unilateral, well, yes, that's true. May have an underlying malignancy, yes. They have associated with an invasive ductal carcinoma. Invasive ductal carcinoma can be present associated with this. I'm not trying to say this is an invasive ductal carcinoma, but if at all you kind of take a deep biopsy, there's a chance that beneath this, inside the breast tissue, they are associated with the invasive ductal carcinoma. And the carcinoma, so they are basically classified as the carcinoma in situ of the breast. And also this image is very, very important. So how do you get to know that this is a Paget's disease? So the nipple areolar complex is completely destroyed. So Paget's disease, like this is a kind of a spot diagnosis. Whenever you get an image like this is what is a Paget's disease. That is the nipple areolar complex is completely destroyed. Okay, I hope you are able to understand and appreciate this particular thing, right? Okay, now yeah, so 73-year-old kind of bed sore, 15 years. What is the grade of this particular bed sore? So more or less like kind of repeat kind of a question. So yeah, what is the grade of this particular bed sore? Can you please help me? Yeah, definitely. It is a grade 4 bed sore. Okay, so what is this? This is a grade 4 bed sore. Why do the bed sores form? Because of the prolonged immobilization. Okay, prolonged immobilization. Okay, so what happens because of this prolonged immobilization? What happens is that there is a increase in the pressure in the tissues. Okay, in the tissues the pressure basically increases, and this particular pressure goes beyond what? Okay, so what is the level beyond which that particular pressure goes in order to lead to the formation of a bed sore? So if at all this particular pressure goes beyond 30 millimeters of mercury, okay, if at all the pressure goes beyond the 30 millimeters of mercury, then you basically like this increases the chances of the development of a bed sore. Okay, more than 30 millimeters of mercury, which is basically your capillary closing pressure. Okay, so that is what is your capillary closing pressure. Okay, now there's a patient who presented with the pain and the swelling at the angle of the mandible, and the swelling was kind of non-tender and firm for around 3 months. What is the diagnosis of this patient? Okay, so yeah, what do you think? What is the diagnosis over here? Okay, so this is what is the swelling which you're basically seeing below this particular ear. This is the area where it is kind of there. What is the diagnosis? Is it like a mucoepidermoid carcinoma, parotid abscess, pleomorphic adenoma of the parotid, or the basalt abscess? Okay, so yes, the answer over here is definitely a pleomorphic adenoma of the parotid. Okay, so what is this? This is a pleomorphic adenoma. So what is this? This is what is a benign condition. Okay, so this is a benign condition which is pleomorphic adenoma. Okay, so what is this? This is a characteristic location of this. Okay, the most common tumor of the parotid is basically pleomorphic adenoma, and yeah, that is what is the pleomorphic adenoma of the kind of a parotid gland. Okay, I hope you're able to understand this particular point. Now, what is going to happen if at all you? Okay, so what is the management of these particular patients? Okay, the management of the patients with the pleomorphic adenoma. If at all there is a patient with the pleomorphic adenoma. Okay, how are you going to manage these particular patients? Okay, so if at all there is a patient with a pleomorphic adenoma, how are you going to manage these particular patients? Management of these particular patients is, that is the treatment of choices, superficial parotidectomy. Okay, because most of the times what is involved is the superficial lobe. Okay, so only the superficial lobe is kind of involved, and that is why the treatment of choice is basically superficial parotidectomy. Okay, but if the deep lobe is involved, okay, my question is, how will you get to know that the deep lobe is involved? Okay, how would you get to know? So when you do an oral examination, the tonsils and the uvula are basically shifted medially. Okay, so when you do an oral examination, if at all the tonsils and the uvula are basically shifted medially, then you say that, you know what, the deep lobe is involved, and over here what you have to perform is a total parotidectomy. Okay, so now what you have to perform is a total parotidectomy. Yeah, you understand my point? So if at all only the superficial lobe is involved, you perform a superficial parotidectomy, but if at all the deep lobe is also involved, then you have to perform a total parotidectomy. Okay, what about the enucleation? Okay, if you perform an enucleation, is it going to be good? Enucleation, so please try to understand this enucleation is never done. Okay, so you'd never do this enucleation. Why? Oh, it's not like never done. You can do it if you want, that's fine, but it is not preferred. Okay, why enucleation is not done? Because there will be recurrence. Okay, there will be recurrence. Why? Because this pleomorphic adenoma have pseudopodia. Okay, so the pleomorphic adenoma has a lot of pseudopodia. So if at all you kind of remove the central portion of this particular tumor, then what is going to happen? The few foci are going to be remaining, and there will be the focal recurrences in that particular area. You understand my point? So you do not kind of do the enucleation. Enucleation is not done in these particular patients. That is something which you need to understand. Okay, now. There is a middle-aged female who was exposed to a radiation exposure. So basically there is a female, middle-aged, let's say 30-40 years. The patient was exposed to the radiation exposure for the painless flowing midline. Okay, so radiation exposure, the patient was kind of exposed in the past, and now the patient is basically coming to with a slow growing midline anterior neck swelling. After 6 months, bilateral cervical lymphadenopathy developed. The surgery was done, and the image of the biopsy has been shown to you. What is the diagnosis? Okay, so in other words, what they're trying to tell you, that there is a patient who had received the radiation in the past. Now the patient is basically having a midline swelling, and there are cervical lymph nodes which are also involved, and the biopsy has been shown to you. Okay, so yes, the answer over here, okay, which of the following is not true? Okay, so yes, the answer over here is A, definitely. FNAC is definitely diagnostic. And what is the diagnosis over here? The diagnosis over here is a papillary carcinoma of the thyroid. Okay, so papillary carcinoma of thyroid, and what are you basically finding over here? This is what is called as a psammoma bodies. Okay, what are these? These are the psammoma bodies which we have. Are you understand my point? So what are these? These are the psammoma bodies which you are basically having. Okay, psammoma bodies, papillary carcinoma thyroid, all these particular stuff. I hope you have understood this point. Okay, now let's talk a few of the points about your papillary carcinoma thyroid. So papillary carcinoma thyroids are, okay, so let's talk about papillary carcinoma of thyroid. So if I ask you, what is the most common thyroid malignancy? Yes, I hope that you're answering that it is papillary carcinoma thyroid. So this is the most common. This is also the one which is having the best prognosis. Okay, this is also the one which is having the best prognosis. The investigation of choice over here is FNAC. And what you're going to find on the FNAC? On the FNAC, you're going to find psammoma bodies. Psammoma bodies. You're going to find what is called as a pseudo grooving. This is not that important. Pseudo grooving, and more important than this is orphan nuclei. Okay, so what you're going to find? So mom bodies, pseudogroving, and orphan NEI nuclei. So yes, orphan NEI nuclei and some mom bodies. These are the things which you definitely need to remember. Okay, orphan NEI nuclei. So these are the things which you're going to find on the like FNAC in these particular patients. Okay, I hope you have understood this particular point. Now, if I ask you what is the genetic mutation associated with this papillary calcium thyroid, can you please help me with this? What is the genetic mutation which is associated with this? So the genetic mutation which is associated with this, what you call as a papillary calcium thyroid, it is BRAF gene mutation. Okay, so there's BRAF gene mutation. Please try to understand this particular point. Okay, so BRAF gene mutation is something which is associated with this papillary carcinoma of thyroid. Okay, so I hope you have understood this particular point, guys. Okay, now there is a patient who came to the emergency with a stab injury in the abdomen. The vitals are stable. So there's a patient who came with a stab injury, anti-abdominal stab wound, and the vitals of this particular patient are stable. The image is shown kind of below. What is the next step in the management of this particular patient? Okay, so this is again a repeat question, guys. So can you please help me with this here? What is the answer over here? So there's a patient who came to you after the stab injury to the anterior abdomen, and the vitals of that particular patient are stable. What is the next step in the management of this particular patient? Local wound exploration, IV fluids, wait and watch after dressing, exploratory laparotomy. So yes, absolutely right. Many of you guys have answered it correctly. The answer over here is A, that is a local wound exploration. See, whenever there is a patient who is coming to you with a stab wound, what you want to understand, what are you worried about? Okay, for example, let's say this is the knife and somebody kind of hits me with a knife. What is going to happen? Or why, what, and if I come to you as, and you are my treating doctor, what will be you be concerned about, that whether this particular knife has caused injury inside the abdomen or not. And in order that this particular knife would have caused injury to the abdomen, only when the peritoneum of the abdomen would have been breached. You understand my point? Only when the peritoneum is breached, only after that this particular knife would have caused injury to the abdomen. You understand my point? So in order to see what is the aim, okay, so whatever we do in our life, we always should have one particular aim, right? So what is the aim of this particular local wound exploration? The aim of this particular local wound exploration is to look if the peritoneum has been breached or not. Okay, so yeah, that is why you perform the local wound exploration. Why do you want to perform the local wound exploration? To see whether the peritoneum has been breached or not. Because if at all the peritoneum, okay, if at all, let's say the peritoneum has not been breached, there is no way that this would have caused any intra-abdominal injury in my body, right? You understand my point? So if at all the peritoneum has not been breached, I can simply take the stitches and I can send the patient home. But if at all the peritoneum has been breached, then I'll have to admit this particular patient, monitor these particular patients, and if at all the patients deteriorate, then we'll go ahead and do the surgery. So simply coming back to this particular question, the patient is having an anterior abdominal stab wound. I hope you're able to appreciate this, and that is why what you have to do in these particular patients is a local wound exploration. Why? Because we want to see whether the peritoneum has been breached or not. Okay, I hope you have understood. Now let's talk about this particular question. So there is a what you call as a 35-year-old kind of a patient presented with the severe abdominal pain and the vomiting. His vitals are stable. The radiograph has been kind of shown below. What is the most effective way of treating this particular patient? Okay, so what is the most effective way of treating this particular patient? So just look at this particular x-ray first. Okay, now can you please tell me what is the most effective way of treating this particular patient? Is it like the gastric lavage with the cold saline, tracheostomy, chest tube insertion, or resuscitation and the laparotomy? So answer over here is, yeah, what is the answer over here? Yeah, this is a gas under diaphragm. Okay, so what are you basically finding over here? This is what is the gas under the diaphragm. Okay, and yeah, what you have to do? Obviously you'll have to kind of do a resuscitation and laparotomy, because whenever you have this, okay, so gas under diaphragm basically means that there is a visceral perforation. What do you understand by the visceral perforation? That is some or the other part of the intestine has kind of ruptured. Stomach, intestine, we don't know. Okay, that is why it's called as a visceral perforation. And whenever there is a visceral perforation, what you have to perform over here is we have to perform an exploratory laparotomy. because what you have to do now, you have to kind of put an incision and you have to explore the abdomen and you have to kind of find out where exactly is this particular perforation present, and wherever this particular perforation is present, you will kind of repair that particular stuff. You understand my point? So gas in a diaphragm, visceral perforation, what you have to perform is an exploratory laparotomy, and obviously you will start these particular patients on the fluid resuscitation. I'm sorry, because of that watermark, it was not visible properly, so you have to perform a resuscitation along with that a laparotomy. Okay, exploratory laparotomy. I hope you have understood this particular point, guys. Okay, now let's move on to the next question. So here there is a 30-year-old whatever. So 30-year-old male patient is present who presents with a painful perianal nodule. So there is a perianal nodule as well on the buttocks, and there is a serous discharge. So there is a serous discharge. What is the most probable diagnosis of this particular patient? Okay, so yeah, what is the diagnosis of this particular patient? Can you please help me with this? Yep, what is the diagnosis? So the diagnosis of this particular patient is fistula in ano. Okay, it is not a pilonidal sinus. Pilonidal sinus is not like that. Okay, pilonidal sinus is what is going to occur in the sacral region. Okay, so this is what is your fistula in ano. What is this? This is what is called fistula. This is what is a perianal fistula. Please try to understand over here. Okay, so I'll just zoom in. My bad, I did not zoom in earlier. So this is what is an external opening of that particular fistula. Okay, you understand my point? So this is what is an external opening of that particular fistula. So what are you dealing with over here? This is what is your fistula in ano. Okay, what is this? This is what is your fistula in ano. I hope you are able to appreciate these particular stuff, right? Okay, serous discharge coming out, fistula in ano. Okay, now one of the treatment measures of this is, what is this? Okay, so it is written over here. This is what is a seton. Okay, so if I ask you what is a treatment of choice, okay, what is the treatment of choice of your fistula in ano? Fistula in ano. Okay, so if at all, let's say there is a patient who is having a low lying or a simple fistula. Okay, simple fistula. Okay, please try to understand this point. Low lying means that it is not above the internal sphincter as well. Okay, it is basically a low lying fistula or a simple fistula. Over here, what you have to perform is you have to perform what you call as a fistulotomy. Okay, fistulotomy, that is you have to kind of open that particular fistulous tract like this. Okay, so this is what is called as a fistulotomy. But if at all, let's say there is a high lying fistula, high lying, or there is a complex fistula. Okay, if at all there is a high lying or a complex fistula, then you have to perform a seton. Okay, so I'll not go into the details of this, but then the seton is kind of preferred. Or if at all they give you that there is a patient who is immunocompromised or the patients are having a very poor healing capacity, then you have to perform a seton treatment. And what is this particular seton? Seton is basically a thread which you basically pass through the internal and the external opening. So as you can see over here, you've passed this particular thing in from the internal opening, external opening, and you have kind of tied it like this. So this is what is a seton. Okay, seton. Okay, so yes, Nidhi, what you have said is fistulectomy. So please try to understand, fistulectomy is never done this. Okay, so please try to understand, fistulectomy is not done for the patients with the fistula in ano. What do you understand by the fistulectomy? For example, this is a fistulous tract. This is an, let's assume that this is an internal opening, this is an external opening. What do you understand by the fistulectomy? You cut this particular fistula and you remove that particular fistula. That is what we are doing. But that's what I was trying to explain, Unity. So I hope you have understood now. Fistulectomy is not done. Okay, what you basically do is fistulotomy. What you do is you open that particular fistula. Okay, you kind of open this particular fistula. So now what is going to happen, because of the granulation tissue, this particular fistulous tract is going to get filled up. Okay, I hope you have understood. Do not mark it as a fistulectomy, it is a fistulotomy. Okay, now there is a 30-year-old male patient presenting to the casualty after the motor vehicle accident. So there was a, whatever the road traffic accident, motor vehicle accident happened, and he has the bruise on his kind of chest. His pulse rate is 120 beats per minute. The BP is 90/60. Respiratory rate is 40 per minute. The chest X-ray has been performed. What is the next step and appropriate step in the management of this particular patient? Okay, so I'll just zoom in. Look at the image. Okay, what is the diagnosis over here? The diagnosis over here is that there is a pneumothorax. Okay, so there is a pneumothorax. So from the X-ray, what you basically get to know that, okay, the patient is basically having a pneumothorax. So there is a black, like that particular lung has become very, very, very black. So that is what is a pneumothorax. Now, when we kind of look at this particular clinical scenario, the pulse rate is increasing, the BP is reducing, the respiratory rate is high. So I would argue that, you know what, it is not a simple pneumothorax. What is this? This is what is your tension pneumothorax. The tension pneumothorax. So if at all there is a tension pneumothorax, ideally the emergency treatment should have been a wide bore needle insertion, but that is not given in the options, and that is why you have to kind of go ahead with this chest tube insertion and the drainage. Okay, so what is the management of this particular thing? Chest tube insertion and the drainage. Ideally what you should have, pericardiocentesis is not. Okay, so Sakshi, yeah, please try to understand over here. Pericardiocentesis is basically what you do in the patients with the cardiac tamponade. The cardiac tamponade, here what you have is a tension pneumothorax. So ideally you should have put a wide bore needle in order to kind of drain the air out of it, but that is not what you're doing. What you're basically doing over here is that you are basically like, that is not given in the options, that is why you're not doing it. So what you have to kind of do is you have to put a ICD, intercostal drainage insertion, ICD. That is what you have to kind of do in these particular patients. Hope you have understood this point. Okay, now let's say there is a 45-year-old patient who kind of complains of a recurrent swelling on the one side of the neck. Okay, so there is a recurrent swelling on the one side of the neck, 45-year-old kind of a patient. She's afraid of eating food as this particular swelling worsens. Eating food basically worsens this particular swelling. The imaging was performed and which has been shown below. What is the most likely diagnosis of this particular patient? Okay, what is it? Yeah, it is a cyalolithiasis. Okay, so please try to understand what is this. This is a cyalolithiasis. Okay, very important. Okay, now let's talk a bit about this. Okay, so if I ask you, what is the most common salivary gland? What is the most common salivary gland where stones can occur? Stones can occur. Can you please help me with this? What is the most common salivary gland where the stones can occur? It is not sublingual. Okay, it is submandibular. Submandibular salivary gland. Okay, it's a submandibular salivary gland. Why submandibular salivary gland? So what you need to understand is that we have this particular gland. Okay, so this is what is the submandibular salivary gland. So we have this particular, so like this duct of the submandibular salivary gland. Now what you need to understand is that this particular duct of the submandibular salivary gland is hooked by a nerve. Okay, so there is a nerve which is hooking this particular duct of the submandibular salivary gland. Okay, so there is a nerve which is hooking this particular duct. Okay, so what is the name of this particular nerve? Anybody? So this is a lingual nerve. Please try to understand. The lingual nerve is basically hooking this submandibular duct. So if at all this particular duct is hooked by the lingual nerve, what is going to happen? There is going to be anti-gravity drainage, and because it is anti-gravity drainage, there is a chance that the stones can get formed in these particular kind of a ducts. Okay, so that is the reason why the salivary gland stones are most commonly present in the submandibular duct. Okay, I hope you are able to understand. That is the first thing. Now here, what is going to be the clinical features of these particular patients? There's going to be the postprandial swelling. It means that the swelling basically increases after what you call as the swelling increases after eating food, because after eating food what happens, the salivation increases, and as the salivation increases, the saliva is not able to kind of go out very easily, and that is why there's going to be the accumulation of the saliva and there's going to be a lot of pain. Are you understanding my point? So this is okay. So why they had given you this, that the patient is afraid of eating food, because the swelling and the pain basically increases after eating food. And why? Because after eating food the salivation increases, and that is what. Treatment is simple. You have to kind of do a surgery and you have to put an incision on that particular duct and you have to remove those particular stones. Okay, so that is how you kind of treat it. Okay, so you have to put an incision, remove the stones, and then suture that particular duct again. Okay, sometimes they just leave that particular duct like that, because if you suture then the stenosis might happen. So what they say is give a very small incision, remove the stones and just leave it like that, or if you want you can just gently suture that particular duct. That's fine. Okay, got it. Now there is a patient who presented with the presented to the emergency with the claudication of the calf muscles, numbness of the thigh, and the impotence. There is a bilateral resting pain. The image has been shown. What is the artery involved? So yeah, now you have to kind of tell me. So first of all, can you tell me what is the diagnosis of this particular patient? So what is the diagnosis of this particular patient? The diagnosis of this particular patient is PVD. Okay, what is the diagnosis? It is a peripheral vascular disease. Okay, it is a peripheral vascular disease. Okay, now what is the kind of yes, absolutely right. Okay, so what you need to understand, when you have these particular constellation of symptoms, you have to see what is the most proximal enough symptoms. So we have this impotence. Okay, so because there is an impotence, right? So because of the impotence, you understand that the iliac vessels are involved. So here the aortoiliac bifurcation is kind of involved over here. Okay, I hope you're able to understand this point. Yeah, Lehret syndrome. Okay, very nice. Okay, so I hope you have understood this point. So the involvement is quite above. Iliac vessels are involved, and that is what is your aortoiliac bifurcation. Okay, I hope you're able to understand Lehret syndrome. Got it. Good. Now, there's a 22-year-old man who underwent a surgery on the chest after the road traffic accident 1 year back. Now the image of the lesion has been shown. What is the most probable diagnosis of this particular patient? I'll just zoom in. What is the diagnosis over here? One of the most simplest of the questions ever. So this is what is the abnormality of the scar. So what is this? This is what is your hypertrophic scar. Okay. So please try to understand what is the diagnosis over here. The diagnosis over here is an hypertrophic scar. Okay, so what is the basic difference between hypertrophic scar and the keloid? In the hypertrophic scar, the scar is basically limited to the boundary. In the keloid, the scar is basically going beyond that particular boundary. So this is what is a hypertrophic scar. Okay, I hope you have understood this particular point, guys. Okay, got it? Now, let's move on to the next question. So there's a lady with the varicose vein has an eczema. So lady with the varicose vein has an eczema. Okay, so what is the stage of the clinical classification as per the CEAP? Okay, so we are talking about the CEAP classification over here. What is the C, like the clinical classification as per the CEAP? Okay, what is it? Is it like the C2, C4A, C3 or the C4B? Okay, yes, the answer over here is C4A, guys. Okay, what is this? This is a C4A. So please try to understand this. CEAP classification is very, very important. Okay, so let's try to revise the CEAP classification. In this, what we are going to do is we are going to simply revise the C stage at this point of time. Okay, so what is the C0? C0 basically means normal individuals. Normal individuals. Okay, then what do we have? What is the C1? C1 is basically when there is like a development of reticular veins or telangiectasia. Okay, reticular vein or the telangiectasia, that is what is the C1. What about the C2? What about the C2? C2 is basically asymptomatic varicose vein. What is the C2? C2 is basically asymptomatic varicose vein, that there is a varicose vein, but the patients are having no symptoms at all. That is what is an asymptomatic varicose vein. What about the C3? The symptoms start, but the very, very basic of the symptoms have developed at this point of time. So edema. Okay, edema has kind of developed. That is what is the very, very basics of the symptoms. Okay, then what we have is a C4. C4A basically means that involves pigmentation and eczema. Okay, pigmentation and the eczema. Then we have a C4B. In the C4B, what is there? We have a lipodermatosclerosis. Then what we have is we have C5. What you have in the C5? So in the C5, what we have is a healed ulcer. Okay, so what we have a healed venous ulcer. So in the C5, what you need to understand is that we have a healed venous ulcer. Healed venous ulcer. And in the C6, what you have is, in the C6, what you basically have is a active venous ulcer. Active venous ulcer. So please remember these guys. Okay, it is very, 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 very important. Okay, right? So the C staging of the CEAP classification is absolutely must know and must remember. So please do remember this CEAP classification. How to remember these effectively, sir? So please try to understand. Just try to understand the patients of a varicose vein. Okay, when the patients of a varicose vein comes to you, like you and me at this point of time, probably we are normal individuals, right? So we have C0. Now, when the disease starts, the first what thing basically happens is the reticular veins. So that is what is the C1. Now, after the reticular veins, over a period of time, after a few years, the patients would develop a varicose vein. When the varicose veins are going to just develop, there's going to be no symptoms at all. So that is what is a C2, asymptomatic varicose vein. What is the first symptom which is going to occur? That is an edema. That is what is a C3. Now, over a period of time, even at this point of time, if the patient doesn't take good care, then the two things can happen, that the RBCs can come out and they can kind of lyse and there can be pigmentation, and at the same time the WBCs can come out, and because of this there can be lipodermatosclerosis. So that is what is your C4A and the C4B. Now the skin has become very, very thinned out, and even at this point of time, if at all the effective treatment is not given to these particular patients, the patients will land up into ulcer, and always an active ulcer is more dangerous than the healed ulcer. So that is why the active ulcer is C6 and the healed ulcer is C5. Okay, so I hope you've understood. NARDS. Okay, I hope you've understood. So this is, see, whatever you kind of do in your life, always try to correlate with the patient. So if you just remember any particular patient of a varicose vein, the journey of a patient of a varicose vein, you will understand the CEAP classification. Am I hoping, like, I hope you have understood this particular point, right? Got it? Okay, now moving on. So which of the following statements is true about the suture material in this particular image? So what are you basically seeing in this particular image? You are seeing a catgut suture. So which of these particular things is what you call as true about this? Okay, so made by the rapid submucosa, made by the cut submucosa, cat submucosa, non-degraded, degraded by the enzymatic degeneration. Okay, so yes guys, the answer over here is D. Okay, that is degraded by the enzymatic degeneration. Okay, so please try to understand what is this. This is what is a catgut. Okay, it is not from the cat. It is basically derived from the submucosa of the intestine of the sheep. Okay, so please try to understand, it is derived from the submucosa of the intestine of the sheep. I hope you are able to understand this particular point. Okay, it is derived from the submucosa of the intestine of the sheep. Okay, now what you need to understand about this is that okay, so what you need to understand about this is, okay, so let's talk about the absorbable sutures. Okay, so what you need to understand about the absorbable suture, the absorbable sutures, they can be either natural or they can be synthetic. Okay, so what are the natural absorbable sutures? The natural absorbable suture is catgut. Okay, that is what is the natural absorbable suture, and the natural absorbable sutures are absorbed by the process of what you call as an enzymatic degeneration. Okay, so they are basically absorbed by the process of enzymatic degeneration. On the other hand, the synthetic, okay, on the other hand, the synthetic absorbable sutures, they are basically absorbed by, okay, so the synthetic absorbable sutures, they are what? So we talked about the vicryl, we talked about the monocryl. Okay, so we talked about this vicryl, we talked about this monocryl, right? So these are basically absorbed by the process of what you call as a hydrolysis. Okay, so by the process of the hydrolysis and phagocytosis. Please try to understand over here. This is how the absorption of these particular things takes place. Okay, yeah, understood? So this is how the absorption of these particular things takes place. Okay, Sakshi, I'll explain the notes probably. Okay, if I have some particular MCQ over here, I'll explain that, but I'll need few images and everything. So if at all I don't remember whether I have put the question on that or not. If not, then don't worry, I'll kind of cover that in the next section probably, because I will need a couple of images for you to understand the notes. Okay, so that's what you need to understand over here. Okay, right. Okay, now what is the ulcer which you are basically having in the, like this particular patient is basically having which type of an ulcer? So can you please help me with this? Is it like a malignant ulcer, arterial ulcer, venous ulcer, or the trophic ulcer? What is the thing over here? Please tell me guys, what is the answer? What do you think? What do you think? What is the type of an ulcer which is present in this particular patient? Okay, so it's not a trophic ulcer. Yes, it is an arterial ulcer, guys. It's not a venous ulcer. Come on, it's not a venous ulcer. What is this? This is what is an arterial ulcer, guys. Okay, so please try to understand arterial ulcer. So what is the most common location of an arterial ulcer? If I ask you about the arterial ulcer, what is the most common location of this particular arterial ulcer? What is the most common location? The most common location of the arterial ulcer is the lateral aspect of the leg. Okay, lateral aspect of the leg and the tip of the fingers. Okay, so usually the great toe. Great toe. Are you understanding my point? So tip of the great toe and the lateral aspect of the leg, these are the places where the arterial ulcers usually occur. Okay, now what else? The surrounding skin, there are skin changes which develop in this. So what are these particular skin changes? That the skin becomes very thin and there is loss of hair. Okay, so skin becomes very thin and there are the loss of hairs from the skin. So all these are the things which are associated with an arterials. Are you able to appreciate this? So this is basically occurring on the lateral aspect of the leg, this particular ulcer, and the skin is basically very thin and there is a loss of hairs in these particular stuff. So this is what you need to understand about the arterial ulcers. Okay, now What about this venous ulcers? Okay, so a couple of you guys have answered this as a venous ulcer, so please try to understand, that is important. So what you need to understand in the venous ulcer? Okay, so what you need to understand in the venous ulcer, if I ask you what is the most common site of the venous ulcer, can you please help me? What is the most common site of the venous ulcer? This is the medial aspect. Oh, I'm really sorry, I wrote over here leg. No, it's not the leg, it is basically the foot. Okay, so please, yeah, so my bad. So what is this? This is the lateral aspect of the foot, it's not the leg. Okay, so the most common site of the venous ulcer is what? Yeah, that is what is called as the gaiters area. What is this particular gaiters area? This is the medial aspect of the lower 1/3 of the leg. Okay, so on the medial aspect, lower 1/3 of the leg, what you basically find is the venous ulcer, and this is what is referred to as your gaiters area. Very, very important, guys. Okay, this is what is called as a gaiters area. What is the gaiters area? This area, that the medial aspect of the leg, lower 1/3, this is what is called as the gaiters area. I hope you are able to understand this particular point, guys. Okay, so this is the most common site of the venous ulcer. Most common site of an arterial ulcer is lateral aspect of the foot and the tip of the fingers or the great toes. Okay, arterial is on the fingers or the toe. And if toe is also a type of a finger, right, doctor? So it can occur on any of the toe, like fingers of the lower limbs, but most commonly it basically occurs on the tip of the great toe. Okay, you understand my point? Toe is also a finger, right? I mean, they're the fingers of the feet, right? Yes or no? Right? So yes, so it can occur on any of those particular kind of a things, but it is most commonly present on the kind of a great toe. Okay, so okay, I like you're basically catching me on the English. So fingers basically doesn't mean the fingers. Okay, so if at all there is an arterial ulcer on the upper limbs, okay, if at all let's say there is some peripheral vascular disease of the upper limbs, then yes, the tips of the fingers will get kind of involved, and in the lower limb, yes, the kind of the tips of the, what do you call it, the fingers of the lower limb, that is the toes. We call it as the toes, right? The great toe and the like other toes. So yeah, that is the tips will get kind of involved. Okay, I hope you got the concept over here. Okay, maybe I kind of screwed up it on the English part of it, but I hope you have understood the concept over there. Okay, I hope you understood, doctor. Can we move ahead? Got it? Okay, great. I hope you have understood. If not, you can just put it in the comment box. That's fine. Okay, right. Okay, now let's come to the next question. So the next question over here is that there is a 11-month-old baby who was brought to the emergency with the pain in the abdomen, blah blah blah, multiple episodes of vomiting, and on examination there was a mass which was palpable in the right lumbar region. The barium enema has been shown. What is the most likely diagnosis of this particular patient? Okay, so what is the most likely diagnosis of this particular patient? Please look at the image. Okay, what is the diagnosis? Yes, definitely it is intussusception. Okay, it is an intussusception. What you're basically seeing is a claw sign. Okay, so it's kind of a repeat question. We have already talked about this. So yeah, this is what is a telescoping of the bowel into the other, and what you're basically seeing on this particular barium enema is a claw sign. Okay, so what you basically get is a claw sign. What are the other things which you basically get in the barium enema? So coiled spring appearance. Okay, other thing what you can basically get in the barium enema is a coiled spring appearance. Okay, so that is what you need to understand over here. Barium enema, claw sign, or the coiled spring appearance. That's fine. Okay, right. Now again, this is, I think, a major. Okay, so there's a 55-year-old patient presented to the emergency with the scrotal swelling, ecchymosis, fever, and the serous discharge. Blah blah blah. What is the most probable diagnosis of this particular patient? Okay, so based on this particular image, what do you think? What is the most probable diagnosis of this particular patient? The most probable diagnosis of this particular patient is definitely a Fournier's gangrene. So, okay, of the given away, there's a necrotizing fasciitis of the scrotum. This is what is a Fournier's gangrene. Okay, we have already talked about one particular question over here. So, over here, that is like the skin and the subcutaneous tissue, that is what is having the necrosis and the necrotizing fasciitis and everything. But the testes are basically preserved. Okay, so the blood supply to the testes is preserved because that basically comes from the aorta. That is what you need to understand over here. Okay, right. Now, there's a 28-year-old. Okay, so what is there? There is a 28-year-old kind of a pregnant woman presented with a history of a kind of a decreased fetal movements and the respiratory distress in her newborn. On examination, the neonate appeared cyanotic. Okay, so cyanotic, and there is an increased work of the breathing. So when the child was born, so what you need to understand, there's a 28-year-old pregnant woman, decreased fetal movements and the respiratory distress when her child was born. The child was cyanotic. There was increased work of the breathing. Auscultation reveals the bowel sounds in the left hemithorax. The X-ray has been shown to you. Falling congenital. Okay. Basically, it's a very, very simple question. What they're trying to ask you is that what is the congenital anomaly in these particular patients, and this is what is the X-ray which they have been trying to show you over here. So yes, definitely, what is this? This is what is your congenital diaphragmatic hernia. So can anybody tell me what is the name of this particular congenital diaphragmatic hernia? What is this called as? So this is called as a Bogdalex hernia. Okay, so this is what is called as a Bogdalex hernia. And what is this? Okay, so for those of you who were not able to appreciate, I hope you're able to appreciate, these are the intestinal loops. Okay, so these are the intestinal loops which are basically present in the thoracic cavity. So what they're doing, they're basically pushing the lungs to the opposite side. So they're pushing the lungs to the opposite side, and that is why the patients are having the respiratory distress, and that is why when you auscultate, you are able to hear the bowel sounds in the thoracic cavity. Okay, so Bogdalex hernia, that's fine. Now this is more common on the left side or the right side? Okay, so on the X-ray, it is basically shown on the left side. That's fine. But overall, is it more common on the left side or the right side? So you can remember this with the mnemonic of BPL. Okay, so Bogdalex hernia is usually occurring on the posterolateral defect. So there is a posterolateral defect which is more on the left side as compared to the right side. Okay, so there is a posterolateral defect which is more on the left side as compared to that of the right side. Okay, so this is what you need to understand about the Bogdalex hernia. Posterolateral defect more on the left side as compared to that of the right side. Okay, I hope you have understood this particular point. Now let's move on to this. So there's a patient who came with a progressive dysphagia. So what is here? Here the patients are having the progressive dysphagia, which is involving the fluids and the solids. Regurgitation, chest pain is there, heartburn is there, weight loss is there. Barium study has been shown. What is the diagnosis? Okay, so all these particular things are there. Progressive dysphagia is there, fluids, solids, regurgitation, chest pain, heartburn, weight loss, all these particular things. And this is what is the barium swallow. This is the image of the barium swallow which has been shown to you. So obviously it's one of the simplest kind of a question. So what is this? This is what is a bird's beak appearance. Okay, pencil tip, bird's beak, rat tail appearance, whatever you want to call it. So this is what is an achalasia cardia. Okay, now if at all they wanted to mark it as an achalasia cardia, what is the thing which they are going to give you in the history? So the dysphagia is going to be the more to the solids or to the liquids. Okay, so please try to understand that dysphagia is going to be more to the liquids. Okay, so ultimately like even though to the solids there's going to be dysphagia. That is why it is a progressive dysphagia, but the dysphagia will be earlier to the liquids as compared to that of the solids. Okay, now opposite to that, if we talk about the esophageal carcinoma, okay, in the patients with the esophageal carcinoma, over here what you're going to have, here what you're going to have, are you going to have the dysphagia which is more to the solids or more to the liquids? Okay, so over here the dysphagia is basically to the solids. Okay, so the solids, it is first, followed by that to the liquids. Okay, so there's a dysphagia more to the solids as compared to the liquids in the esophageal carcinoma. Okay, I hope you've understood this particular point. Now okay, now this is a good question. Just try to understand this. So there's a 5-day old baby has been brought to the emergency with the bilious vomiting. Okay, so 5-day-old baby brought to the emergency with the bilious vomiting. There's an abdominal destination on abdominal X-ray. There are multiple air fluid levels are seen. There is no gas under the diaphragm was visible. Baby was otherwise stable. What should be the immediate step in the management of this particular baby? And the options are: immediately do a colostomy and fix the obstruction, bowel resection and anastomosis, temporary colostomy and fix the obstruction later, and bowel resection with the coiled silo. Okay, what is the diagnosis over here? Okay, first of all, let me know what is the diagnosis. Okay, what is the diagnosis over here? The diagnosis over here is an intestinal obstruction. Okay, what is the diagnosis over here? It is an intestinal obstruction, and because the patients are having an intestinal obstruction, that's fine, that's great. But yeah, so what are you going to do? So see, try to understand, whenever there is a patient who are having an intestinal obstruction, you do not do some radical kind of thing. So this is like too much, right? Immediately do colostomy and fix the obstruction. No. Bowel resection anastomosis. So you kind of cut the bowel and you do the major supra-major surgery in these. So patients are not in a good physiological state, right? The patients are already having the intestinal obstruction. There is a lot of vomiting. There's a lot of electrolyte loss. The patients are dehydrated. So in these particular kind of patients, what you need to understand is that you have to perform a temporary colostomy and fix the obstruction. So you understand my point? So divergent colostomy. So what you have to perform is a divergent colostomy. Okay, divergent colostomy. Okay, are you understanding my point? Okay, now doctor is basically that Dr. 1 is basically asking Dr. I or Dr. 1, what is silo? So silo is basically a form of a temporary closure. Okay, so what you need to understand, let's say if at all there is a lot of bowel edema and your abdomen is not being able to close in a proper manner, and if at all you pull the abdominal edges and then you just try to kind of suture that up, what is going to happen? The intra-abdominal pressure will rise and the patients will land up into abdominal compartment syndrome, which you don't want. So that is why you basically perform a temporary closure, and silo is one type of a temporary closure. That's what you need to understand over here. Okay, right. Over here, what you're going to do, you're going to do a temporary colostomy with, first you do a temporary colostomy, then you try to figure out where's the obstruction. Once the patients are stabilized, then you go ahead and fix that particular obstruction. Okay, understood. Right. Now, there's a 45-year-old kind of post-menopausal woman, lady, blah, 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 appearance of the breast. What is the T stage of this particular patient? Okay, so yeah, what is the T stage? First of all, what are you basically looking in this particular skin of the breast? Okay, what are you basically looking at this? So this is what is your Pau d'orange. Okay, what is this? This is what is called as a Pau d'orange appearance. Okay, so this Pau d'orange, this is basically called as a orange peel appearance. Okay, this is also referred to as your orange peel appearance. Okay, so this orange peel appearance basically tells you about the involvement of the skin, and the involvement of skin is basically your T4B rise. Okay, T4B, NARDS, it is not T4D. T4D is basically inflammatory breast carcinoma. Over here, the answer is T4B. Okay, so what all other things are included in the skin involvement? So first is your Pau d'orange. What else? So if at all they give you nodules, or if at all they give you ulceration, so these are the parts of your skin involvement. Nodules and the ulceration are the parts of your skin involvement. What is not a part of the skin involvement? So nipple retraction, okay, or dimpling. Nipple retraction or the dimpling, this is not a part of your skin involvement. So please try to understand over here, nipple retraction and the dimpling, these are not the parts of your skin involvement. Okay, so why these occurs? They occur because of the involvement of the ligament of Cooper. So if at all there is a nipple retraction and the dimpling, this is not considered to be a part of your skin involvement. Please try to understand over here, and this is what is basically your T4B, and yes, absolutely right. So why this particular Pau d'orange appears? This is because of the involvement of the dermal lymphatics. So tumor cells have basically involved the dermal lymphatics, and that is the reason why there is a Pau d'orange appearance. Okay, I hope you have understood this particular point. Okay, now we have already discussed this, right? So what is the name of the surgery which is being done over here? Now you please tell me, what is this? Okay, so okay, the name has not been written over here, but what is this? This is what is a longitudinal pancreatico-jejunostomy. So now can you tell me the name of this? What is the name of this? We've already talked about it. Very like I started the second session by this only. Okay, it's not the Whipples. Okay, it is not the Whipples. It is not the Whipples. It is Puestov's procedure. Puestov's procedure. I told you about the Whipples and the Puestov's and everything, right? So what is a Puestov's? You open the pancreas longitudinally, you bring the loop of the jejunum and you attach it. So that is what you're doing over here, right? So what you have done over here, you have opened this particular pancreas longitudinally. What are you basically seeing over here? These are the multiple, what you call as a dilatations and the strictures in the main pancreatic duct. Then what you did, you brought the loop of the jejunum over here. Okay, so what you did, you brought this particular loop of the jejunum over here and you have kind of attached over here. You understand my point? So this is what is called as a longitudinal pancreatico-jejunostomy. That is what is a Puestov's procedure. This is done when the main pancreatic duct is having a lot of strictures and multiple dilatations and the strictures and everything. Okay, so that is all about what you need to understand about the Puestov's procedure. Now, there's a pregnant lady undergoes a routine abdominal ultrasound and the following findings are noted. Okay, so what is the diagnosis of this particular patient? One of the simplest questions ever. Okay, so what is the diagnosis of this particular patient? It is gallstones. Okay, so this is a gallstone. Why amoebic liver abscess? It is a gallstone. So why this is a gallstone? Okay, so this is a gallstone because I hope you're able to appreciate that there is a posterior acoustic shadowing. So what are you basically finding over here? That there is a posterior acoustic shadowing. Okay, so what you basically find over here is a posterior acoustic shadowing. Now you understand my point? So you have a posterior acoustic shadowing. That is what is this. Okay, so gallstones, posterior acoustic shadowing, that is what is the main thing over here for the diagnosis of the gallstones. Okay, so if I ask you what is an investigation of choice to diagnose the gallstones, what is the investigation of choice? What is the investigation of choice to diagnose the gallstones? The investigation of choice to diagnose the gallstones is your ultrasound. Okay, so please try to understand ultrasound is the investigation of choice to diagnose the oh, come on guys, ERCP is not the answer. Ultrasound is the investigation of choice to diagnose the gallstones. Okay, got it? So this is actually the last question which I had in this. We have successfully covered all the 100 image based questions over here. So yeah, kudos to all of us. Now what you need to understand is that I will not talk much over this because already so many videos have already been created about, you know, what NEET PG postponed, what to do now, and all those particular stuff. So obviously, like, you cannot just relax at this point of time. At any point of time, they might kind of re-announce that their exam is happening. I personally feel that they'll give at least 10 days to 14 days for this people to kind of plan the travel and everything. At least 1 week they should give, like 7 to 10 days at least they should give for the people to kind of plan the travel and do other things and everything. Okay, that is the one thing. So obviously you have to kind of continue the reading and do kind of, because see, try to understand that if at all you let loose now, obviously the dynamics are going to change. So those who were a bit less prepared, they might kind of put in their more efforts and they might get a better ranks and all those particular things, especially the freshers. Okay, freshers will have more time now and they can kind of definitely increase their ranks. So please try to understand over here. Don't kind of let your guards down. Please continue reading and yeah, just do that. That's very well. I'm pretty sure that, let's say, a few days before the exam, you might be thinking that, you know what, shit, yaar, ye thodi cheezein reh gayi. If I would have got 1 week more, probably I would have kind of read these particular things in a better manner. So please kind of get onto that. Please kind of do that in a better manner. That is the first thing. Second thing, FMG students, don't be like that, you know what, हमारा भी exam postpone हो जाएगा, man, just chill out. No, not really. There's a high chance that your exam might happen, right? So don't kind of let your guards down. There is a chance that it might get kind of postponed, but do prepare very effectively till your exam date. But that is very important. Okay, so that's all I wanted to kind of say over here. Nothing much, nothing major. All of you are adults, you all know what you have to do. All the best. I hope you kind of learn something from this particular session. Yep. And yeah guys, well, obviously the Telegram will kind of the things will be kind of shared on the Telegram. That's fine. But if at all you guys want to connect with me, I'll just share my phone number over here. So if at all you have any doubts in the future or anything, what you can do is you can just connect with me. So I'll just share my number over here. Just give me a minute. So my number is 98212-54008. Okay, so you can just connect with me. I'm Dr. Pawan. And yeah, it was a pleasure to kind of take this particular session for you guys, and I will continue to take these particular sessions at one point or the other. Okay, so yeah, take care, have a nice time, bye bye, good night, see you, thanks for patiently listening, bye bye, take care.